It's interesting, Brian. It's interesting you said ESPN because Brian has a radio show in Chicago that is on ESPN Radio, and he does that every night during the week, and they tape some shows was it that what you heard? It was him talking advertising. So. Anyway, it's really interesting. Brian, and he deals with all these professional athletes and these, basketball I'm really particularly interested because basketball with a high impact and a full thickness cartilage defect, what do you do, right?
Yeah, so I'll try to keep this very practical to say what really happens. We talk about what might happen, but I'll give some examples about what really happens in this setting with dealing with a high impact athlete. So the first thing that's important is that there is no reliable correlation with what we see radiographically with how an individual feels. Pre-season, we obtain MRIs in all of our Bulls players. We've been doing this for better part of 10 years. And every year we get the advantage of looking back at the preseason MRI to see if anything is new, if they become symptomatic in season. We do the same thing with our throwers for the White Sox because virtually 70% of them have a labral tear. So the analogy in the shoulder is a labral tear. The analogy in the knee is the incidental cartilage or subchondral finding, or even meniscal tear, which has no relevance. So really important to understand that we just don't have a strong nexus between what we see radiographically. Excellent lecture by MRI, but the reality is that MRI is an adjunctive tool, not a diagnostic tool, maybe a prognostic tool, and helps us decide treatment ultimately. But the obvious decision-making starts in the office with walking in the room, the history, the physical, listening to your patient, maybe an x-ray, some advantage from an MRI, but beyond that, most of our decision-making is easy. So to that point, because the incidence is so common, we have to think a little bit before we treat the asymptomatic defect. There are a couple of studies that are listed here that basically teach us the following. Patients who have an ACL tear, who have a concomitant cartilage injury, are doing the same at 10 years and beyond if you neglect that cartilage injury. The flip side is there's some data that shows they actually do worse if you treat that cartilage injury at the time of ACL reconstruction if it's an incidental defect. So one of the things to take home is that we're treating symptoms today and not what might happen in the future because we have a very poor understanding about the natural history of this problem. The other thing that's interesting is we really don't understand why people hurt. This is a female D1 soccer player who had a marrow stimulation procedure, and you can see pretty classic fibrocartilage fill. And she still hurts. And it may have more to do with the surface area of that defect relative to the intact cartilage than it actually does with the repair tissue. Take that same defect, put it in a male with a much bigger femoral condyle, that individual may never know that he or she has a lesion, right? So it's the load sharing that goes along with the normal surface versus the absolute quality of the tissue in the defect area. This is something that comes up a lot, and I hear people say, well, you've got this finding on MRI, you really should decrease your activities because of the risk of progression. This is some work we did looking at not so good literature, but the stuff that we had available, 45 studies to say what's really out there. What does the literature tell us that if you have known articular cartilage damage, what's the association with high-level activities? Should I be concerned that this disease process will progress despite, should we be concerned that it will progress, or should we instill some protective activity modification? And the data basically shows that there's really insufficient evidence suggesting that the participation in sports of any kind increases the risk of knee osteoarthritis. So what do I do with the athlete who we get a preseason MRI that shows tricompartmental findings? Do I go to the agent and say you have to be careful, we should downgrade that player, don't give him long money and so forth? Absolutely not, because I know so little about progression, I know so little about when this individual becomes symptomatic. Yes, intuitively they're at higher risk to become symptomatic versus someone who has no findings, but there's not much more we can say than that with any degree of predictability. So you've heard an excellent talk on non-surgical treatment, and then you're dealing with this what I call the day of reckoning. How do you decide when that patient should have, who's in high-level sports, have a surgical procedure? Maybe benign neglect is no longer an option. Certainly they must have failed non-surgical treatment. They have to have unacceptable pain and dysfunction. In other words, many people play in pain, and that's okay. The real question is it impairing their ability to play at the expected or anticipated level? What would they like to see improve? If they're there because someone told me if I ignore this, it's going to get worse, I get that consultation probably 10 times a year. Patella defect, I was told if I don't fix this, I'm going to shorten my career, right? Not a shred of data that supports that contention. Will the solution predictably deliver what I'm looking for with minimal risk and meaningful upside? And whenever there's an extra-articular option, I think you're going to hear talk on osteotomy, whenever there's an extra-articular option in an athlete, or anyone for that matter, you might want to consider doing that first, because that is something that will endure high-level activities and lead to symptom relief and allow you the opportunity to completely ignore the intra-articular process. Managing expectations is something we hear all the time. We throw it around quite a bit. And the issue is patients really don't care about a statistical difference. You say, well, you know, statistically, there's 98% of the time, or with a 98% certainty, P equals 0.05, they're going to get a difference, or they show that difference. They couldn't care less about that. What they want is something that's meaningful, right? So a minimally clinically important difference to an individual is a lot different than the surrogate that we use in the literature to say that we have a difference with a p-value, okay? So really what we're looking for is, are they well enough to return to sport? That's kind of what we're looking for, a reduction in enough pain and improvement enough associated function. So think of it as often as a light rheostat rather than an off switch, because it's very rare that we hold an off switch in this particular setting. Sometimes we do. Sometimes it's an absolute home run where they have no symptoms whatsoever, but that isn't always the case. So these are the things to consider when making these decisions. What is the least amount I can do to make them better? What will endure his or her habitus, their sport, and the loads imposed without becoming symptomatic again? What will provide the fastest recovery? What will keep them out of the operating room, not burn any bridges nor compromise his asset value? If you give you an upper extremity example, if you do a slap repair and a baseball player who has a partial cuff tear and you repair their cuff, their asset value has been compromised. If you do a microfracture in a high-level athlete, their asset value they may get better, but their asset value has been compromised. What will most likely get them another contract? Because many of these individuals are assets. And I'm not necessarily only speaking about professional athletes. This could be a scholarship athlete whose his or her only chance to get an education is through a scholarship. So there's lots of things to consider when the system they're in. So this is sort of the hot, crazy matrix of articular cartilage. And some of you will or will not know what I'm talking about here. But the bottom line is we have all of these options: debridement, marrow stimulation, abundance of allograft options, osteochondral autografts, ACI, and osteochondral allografts. This is sort of the United States hot, crazy matrix, because you go outside the U.S., you have other options, but this is what we have when it comes to surgical intervention. And there's sort of this inverse relationship between the quality of the repair tissue and the complexity and expense of the procedure. The simpler it is, which may be an option for a patient, maybe less long-lived, you're not obviously getting good quality repair tissue, but you have to ask yourself, does it always matter? So what really happens is the following. I have all those things available, but what really happens is debridement, and maybe debridement again, and then maybe in some instances debridement again, possibly marrow stimulation, and then in the advanced considerations, it's an osteochondral allograft with or without a meniscal transplant and an osteotomy. That's the reality. I can show you all those things. It's very interesting to talk about, but this is what happens in the office. There's something therapeutic about preparing the defect. I showed you that load consideration where you had fibrocartilage fill, where it's a very big surface area relative to a small femoral condyle width in that D1 soccer player. Similarly, when we create a vertical wall, there's some evidence that we can reduce the load that lesion sees. So you can take a symptomatic lesion, change the geometry of it, just make a vertical wall, and that may render them less symptomatic. It's a lot like driving over a pothole that has sort of this crater that's got a subtle embankment. You know when you drove over it with your tire, versus a vertical wall where you drive over it where it's smaller than the diameter of the tire. You have no idea that you drove over it. The best analogy I can tell you is OCD. Osteochondritis dissecans, once you remove a loose piece, is an incredibly well-tolerated disease. Most patients will thank you, never have a problem again, and that's because the disease process isn't palpated or felt by the tibia. It's usually on the upslope and it's a contained defect, and they don't even know they have it. What about debridement? This is a study that's sort of highlighted, and there's others in the literature, but we looked at our patients who were going to get autologous condylocyte implantation. We went in and we biopsied them under the pretense that they were symptomatic and they'd have to have further treatment. 44% of them got better with their biopsy. 61% of them reported symptom relief with debridement. So there's data to show that you can temporize these patients for some period of time. This is a series from Jimmy Andrews, who looked at 52 athletes that showed that 67% of them returned to play in the NFL after 8.2 months after chondroplasty. But microfracture was less likely to return them to play. Now, at its face, you can take this study and say, don't do microfracture. It's a silly conclusion because those who had microfracture were typically very different patients that underwent debridement, right? So to say that microfracture doesn't work is not really a correct conclusion. It doesn't work in some people because they have a terrible problem, not because microfracture is bad, because microfracture can work in high-level athletes in the right setting. So you got to twist the conclusions around from that study. So this is a 31-year-old NBA player with an awful-looking femoral condyle. There's some sclerotic change. Injections have helped him initially, was in season and had 1 year left until free agency. All those things are relevant because your decision is not just made in the context of I have pain or swelling and that X-ray and MRI looks like that. They're in a 1 year deal and they're trying to make good decisions for that particular athlete. This is what was done. I got in there, he had some mechanical symptoms of swelling, went in, and you can see how the zone of injury is much smaller than what you see on the MRI. But this is all we did. We debrided it. He returned to play in 3 weeks. He's now 3 years out, and he still has a veteran contract with that treatment. Never did anything else other than debride him. What about microfracture? Let's say it doesn't work, or you feel that you need microfracture to get them better. There is actually very good data that shows that you can return athletes to a high frequency when it's performed technically correct in virtually any sport category. Microfracture can, in fact, work. Now, it may not work forever, and it may take time to get well, but it can work, and you're generally not burning any bridges. This is a female D1 basketball player. She's 21. She's in her last year at DePaul. She's about to go out into the draft, and she's purported to be the first-round draft pick in the WNBA. She has lateral-sided knee pain, a little bit of a meniscal signal, a small focal defect of her femur. She has achiness. She swells. Injection didn't help, and she wants to get ready for the summer. She has about 6 months to get ready, but she'd have to miss her season if she undergoes treatment. So we did a lateral meniscectomy. I don't think she's going to get better from that lateral meniscectomy. I don't think that's her problem. We debrided the defect, which really didn't have a lot to debride. We removed a small loose body from that defect, but she would not complain really of any high-level mechanical symptoms. It was sort of achy, weight-bearing pain. So then you're left with, is this enough to make her better as she's going to go out into the real world and try to get a job as a professional athlete? So the decision was no in my mind. Now, I could have done an osteochondral autograft, but I worry in females about patellofemoral pain, or I could have done a microfracture, small defect. The literature would support that in this case, and that's what we did. We did marrow stimulation. It took her 8 months before she said she felt well. She didn't say I felt better in 3 or 4 weeks. Therefore, obviously, the debridement didn't do a whole hell of a lot. Once we let her weight bear, she still didn't feel well. But if you ask her how long it took her legitimate 8 months to say, I can play basketball. So at least intuitively, I believe she really needed that technique to get her back what she was looking for. If she was better at 6 months, would have let her go back to play. Osteochondral autograft has very good support, all things being equal, compared to marrow stimulation. I just don't believe it personally. So if you ask me my own personal bias, it doesn't mean I'm right. It's just been my personal experience. I don't find very many small defects that need treatment. Most of those do well with debridement, and I'm not really willing to incur the other morbidity when I think I can get it right with marrow stimulation. And if they fail marrow stimulation, I'm likely to jump next to an osteochondral allograft. But I would fault no one in this room for pulling an osteochondral autograft as their first-line treatment for a smaller defect. The literature would support it, and others' experience does support that. ACI, it's a very expensive technology. It's now matrix-associated cell transplantation. Another situation where there actually is good data that shows that individuals can get back to sport, although there's some particular challenge with stopping and starting and things of that nature. And compared to marrow stimulation, ACI does seem to do better, all things being equal, in a couple of prospective studies. So it's an option. It's just not one of the options that I typically pick in this patient group. This is still my go-to, and the reason I like an osteochondral allograft is it's predictable, it's relatively low morbidity, it rarely catastrophically fails, and we have very positive experience on the glenoid side, the humeral side, in the elbow now, in the hip, which I don't do, and the ankle, which I don't do, and most specifically in the knee. It seems to have the greatest track record for cartilage injury. Now I'm going to give you an example. This is a salvage situation. NBA player, horrible surgical history, previous ACL, meniscectomy, microfracture, continued pain and swelling. Do you have sound back there by chance? Can you just raise a hand if you have sound? Could you plug into my computer, do you mind? I forgot to ask. So this is what this guy underwent. He had a osteochondral allograft of the trochlea, very well, good size match, it can be done. Had an osteochondral allograft of his femur. This is really his last shot at getting back. And he came back in recently. I don't know if you could run that. He came back in recently. He's 2.5 years out. Is there? Yeah. So you're now 2.5 years out after your right knee cartilage transplant.
Yes.
How long did it take you to get back to a level that you could play competitively with basketball?
I say it took me about a little over 18 months, probably about a year and a half. Yeah, probably 18 to 20 some months.
And at that point, you actually got back on a court, right?
Yes.
And you played for a full season?
I played a full season.
And what percent would you say you were at in terms of improvement?
I say I was about 85%.
Okay. There were still some things you were having trouble doing?
Yeah, there were some things. I mean, it was just mainly just soreness and discomfort at times.
So the pain you had before your surgery, was that completely gone?
That pain was almost completely gone. I say about 95% gone.
All right, so the point is that that's a pretty classic outcome when you get it right. That guy had no other solution. Now he's done. He played for a year, year and a half, and now he's going to be an assistant coach in Utah. But the point is he got what he wanted. But you never go into that equation saying you're going to get it. You just say, look, you can't do it without it. Hopefully I'm not going to hurt you, and this is your only chance to get what you're looking for. That's kind of how the discussion goes. So there's actually, just like meniscal allografts, pretty decent data with osteochondral allografts in high-level patients. In fact, I would say that this data is better if they have an articular or an osteoarticular problem. And all things being equal, I would much prefer to have an osteoarticular problem than a meniscectomized state, because an osteochondral allograft, once healed, can pretty much endure anything, just like an osteotomy. I do worry about a meniscal allograft, obviously, for the obvious reasons, but flip side is if they need a meniscal allograft to get well, it's just another meniscectomy, right? You know, they go in and they get trimmed up. But you'd prefer them to get better with a realignment procedure and an allograft to the cartilage and avoid a meniscal transplant if you can. So there seems to be this allograft frenzy, just like we're seeing in injectable biologics. This is what we see in the United States because the bar is very low. The pathway is called a 361 pathway. It's basically minimally manipulated tissue or allograft tissue that the FDA has very little oversight on other than good manufacturing practices. So this is what's available, and I trust me, there's nothing I can tell you to help you sort out when you should use each of these things. But they all follow the basic premise of using living articular cartilage in little pieces or in sheets and putting it on top of the defect. They all kind of do that. The last one, the BioUni, is really not what I just said. It's an osteochondral allograft, but it's a way to treat larger arthritic areas that are more in an oval configuration. So de novo NT was one of the first surface grafts on the scene, and there's pretty decent data. This is second look arthroscopy in the bottom right, that it can work as little pieces of juvenile cartilage placed in the defect. They will actually adhere to the bone and start laying down matrix. We've looked at this in our laboratory with Susan Chubinskaya, where you can actually see these cells migrate out and lay down matrix. This is an early case of ours, 29-year-old Olympic wrestler, 1 year in knee pain prior to debridement, unable to compete. This is his debridement, that's his tibia. And he had so we marrow stimulated that, and then the lateral femoral condyle, we did a patch over morselized juvenile cartilage. And he actually did get back. He was an alternate to the Olympics. And amazingly, it worked. It was bipolar disease. He really didn't have any other options. He was out for sure. Nothing was working. And that's what we did. Could you do other things? Yeah, you could. I don't know if an ACI or an allograft osteochondral would have done it. Probably would have, but that's what we chose at the time. And successfully were able to get him back. Another interesting one. This is a 24-year-old lineman in his contract year. Years of medial pain. He's unable to continue. You see an osteochondral signal there. And did not want an osteochondral allograft agent. Everyone was opposed to it. This is his defect evaluation. Now, again, what you see is the MRI looks a lot worse than what we see arthroscopically, but if you ignore the MRI and just treat the defect, that's probably not telling the whole story. Again, the analogy, it's like those of you who treat rotator cuff, it's like having a small partial thickness tear where if the MRI has a lot of tendinopathy and you get an arthroscopy and it looks like the rest is going to go. It's kind of like this. The zone of injury by MRI is much bigger than what you're seeing arthroscopically, and maybe we shouldn't ignore all that. But in this case, an osteochondral allograft, which would have been my preferred treatment, wasn't something we were going to do. So he underwent a marrow stimulation, and we prefer drilling now over an awl for a lot of reasons, but we like to drill because we think it's less traumatic, it doesn't cause thermal necrosis, and it doesn't cause a fracture. It gets access to the body's MSCs. We use biocartilage, which is collagen that's basically freeze-dried from a donor, as a scaffold to carry bone marrow aspirate concentrate. You could also use it with PRP. The biocartilage, of those who are familiar with, comes from donor cartilage. It's not a scaffold to regenerate using the same collagen. It's really a scaffold to hold on to the BMAC of the PRP. So if you're thinking, you know, what's it going to look like a year later? Is that stuff still there? It should be gone, but we're trying to hold the stuff there long enough that it makes a difference. And this is an interesting one. This is that same guy's MRI, I kid you not. This is a year later, right? So all of that subchondral changes are gone. So we sort of treated the osteochondral unit with a bypass of an osteochondral allograft, injecting stuff, and he actually got picked up a year later and did quite well. So good anecdotal story, but there's other ways to get it right, as I'm trying to help you understand. So finishing up, make sure we understand that we're dealing with a constellation of things: deformity, instability, and meniscal deficiency. It's not just the cartilage. You're going to hear about osteotomy. I'm just going to tell you that young people can get an osteotomy, and you only got to bring them over just enough to unload the compartment. We're not trying to overcorrect them. This is a great example. This is a soccer player, very high level, obviously. He's in valgus, and he has a cartilage defect. You treat everything, not just fix the defect, but you realign him, and that's his best chance to get back. And the results of osteotomies, you're going to hear, can get an athlete back to sport. So in summary, Chondrosis is often incidental. Non-operative treatment is desired for the performing athlete. Debridement is absolutely desired for the competitive athlete because it's cheap, it's easy, and it's fast. And if you have to repeat it again, it's not dangerous for the athlete. But long-term solutions are an option if you fail a debridement. And the younger, the smaller, the shorter duration of symptoms, the more likely you are to get that patient better. And the final statement is this. We talk about return to play, but because we're talking about athletes here, it's return to play for that athlete in their system. So if you want to go to literature and say, well, it takes 6 months to get an athlete back to play after an ACL. It takes 9 months to get him back with a BTB allograft versus autograft. All that stuff is fictitious because they're functioning in a season with roster changes. They get a new contract, they go to a new team. All these things happen. So to look in the public domain and say how long it takes to get an athlete back is a very poor source of information. So just keep that in mind when you're reviewing the literature. You're much better off looking at your own data, how long your athletes are taking back, and taking the system they function in into consideration, because that's often what returns them back to play, not the treatment that you and I are doing on a daily basis. Thank you very much.